Hello and welcome. My name is Carol Carter, and I'm the founder and CEO of Global Minded. And we are delighted today to have an incredible panel with some of our health equity leaders on health disparities and the long tail impact of the coronavirus pandemic on health, livelihood, and wellness of African Americans. This is our last series this month, and numerous that we have done in honor of Black History Month, and in particular, so many of our Black leaders through the Global Minded inclusive community. Global Minded, for those of you who are joining us for the first time, is about creating a capable, diverse talent pipeline to get more women, people of color, minoritized, underrepresented, and poverty-affected students into the education, economic mobility, and leadership pipeline. We do that through a number of different ways. One is we have these monthly equity events so students can see themselves in the leaders that we feature. Most of them are led by our leaders of color. Many of the panelists are diverse panelists. We also have a daily newsletter where role models from all different backgrounds are featured almost every day of the week. And we have an annual conference, which will be live this June in Denver. And there will be a really strong group of leaders from our health equity team live and in person, along with many of our first generation to college students at that conference. So we look forward to seeing you there. We also have programs at 20 different colleges, and we look forward to expanding those programs out so that there's a strong bridge for students who start college, and they have very strong first 2 years of college where we connect them to role models, mentors, internships, and jobs. So it's my pleasure now to introduce Dr. Pierre Theodore and Dr. Monique Butler, who co-chair these sessions, and they're going to lead us and introduce us to today's guests. Welcome, everyone.
Carol, thanks so much for engaging us today, and what I hope will be a lively conversation around not just where we've been for the last 2.5 years. If we can imagine, it's been so long that we've been struggling with the coronavirus pandemic, but hopefully some of the lessons that we have taken from this experience and some of the inequities that have been unmasked by the experience globally with the coronavirus pandemic, setting us on a course to a more equitable healthcare system in which more people have access to superior care to live productive lives. So I am so delighted to join you today, and I have the honor of sharing the stage with my colleague, Dr. Monique Butler, who will introduce herself in one moment. And we have really a tremendous panel, I think, to discuss issues related to health disparity, both in context of the coronavirus pandemic and beyond. And so what I thought might be a way for us to kick off for just a couple of minutes is just to sort of level set around where we are in terms of certain sets of health inequities related to the coronavirus pandemic, and then turn it over to Dr. Butler for her introduction, and then to our panelists. Could not be more delighted to join Dr. Sheila Davis, Dr. Stacy Walton, and also Olamide as well, who is joining us, Ogunnika as well, to sort of present themselves and tell us a little bit of their background with respect to health inequities. So with that as a backdrop, what I'd like to maybe start off is just reminding us, where do we sit today? And when I say today, I mean this final day of Black History Month. Fortunately, we also seem to be at the tail end of still another Omicron spike. But as we all know, this virus has had several surprises for us over the last couple of years, hasn't it? There are other variants that exist. And frankly, until globally we have control over the coronavirus, I don't think it can reasonably be said that we've moved beyond it, despite this very promising graph that we see here. We have what we can consider now as projections that we are at a flat point in the mortality due to coronavirus. This is data from IHME, the Institute for Health and Metrics and Analysis and Evaluation, in the University of Washington. And just as of this month, we're at a point where we can project no further acceleration in deaths, provided that there isn't an additional spike that comes from an undiscovered variant of the disease. At this point, I'd say most of us are used to some graph or series of graphs like this from the Brookings Institute that demonstrates the disparate impact of COVID-19 by race and ethnicity. I don't think anything here comes as a surprise. This was over a few months, quite a long time ago in 2020. The point being the differential impact of the coronavirus at its apex on communities of color. But if you actually look a little bit more deeply into the numbers, what we see is that it's particularly profound among younger populations. From 35 to 64, the difference can be tenfold over the mortality rate that's experienced by the general population or Caucasian population. So really a profound difference. And I'll end with this remark. This is a slide that I go to often with my team, which is to say, you can always look at a difference in healthcare outcome and assume that there's a biologic process, but really what are the upstream determinants that are driving that biologic process? And that is, in my mind, the essence of social determinants, the essence of overcoming health inequities. So with that thought as sort of an introduction, I'll turn it over to you, Monique, perhaps to introduce yourselves and then open the discussion with our talented panel.
Sure. Thank you, Dr. Theodore. Appreciate this opportunity. Thank you, Global Minded, again, for the opportunity. I am Dr. Monique Butler, and just a quick overview of who I am. I'm an internal medicine physician, first generation college graduate, and first physician in my family. I'm currently the division chief medical officer over 15, soon to be 17 hospitals in the North Florida division that range from Pensacola west to Gainesville east down to Orlando. And so great to be before you today as I focus on population health. I'll tell you, I want to move aside and get to our great distinguished panel here, but I also want to be able to talk quickly about one of the most important aspects of decreasing health disparities and increasing health equity, and that is with our education pipeline. We just signed a big contract with the Florida A&M University to ensure that we have a pipeline of diverse candidates coming out of their school of allied health for our respiratory therapists, but then also leadership within our hospitals. That's the key point of one of the key points of decreasing health disparities, and that's to make sure that we have the right people at the table to understand and make those decisions and decreasing those profound statistics that Dr. Theodore just mentioned. So I'm going to stop there and turn it right over to Dr. Stacy Walton to give us a 2-minute introduction. And then after that, we'll hear from Dr. Sheila Davis and then Olamide. So, Dr. Stacy Walton.
Good morning, good afternoon, everyone. Thank you for this opportunity to be part of this learning space. My name is Dr. Stacy Walton. I'm actually a semi-retired pediatrician. I spent the first 10 years of my practice in health, in hospital and medical schools, in teaching medical students and residents, cross-cultural communication and cultural competency skills. I then went on to work for a very, very, very large HMO for the next 15 years as their diversity champion and working very closely in the Diversity Council. People always ask me as a physician why I'm involved in DEI, diversity, equity, and inclusion. It's been a passion of mine since my undergraduate years in cultural anthropology. And by virtue of who I am and my lived life experiences throughout my career, education and professional career, I was always pulled into these conversations to support diversity efforts wherever I found myself. I now am, since George Floyd's murder, I've been spending at least 50% of my time in the racial healing space. And that includes in healthcare arenas, but also in community arenas. And I don't know why I'm so nervous. I just have to say that out loud so that I will relax. I think it is because I know that this topic is so important and so vital for us as a community to keep alive. Dr. Theodore shared with us this plateau of these encouraging statistics around COVID-19, but the reality is the pandemic showed us where all the cracks are, made them visible to the entire world. And we have to continue to work towards making things better. And I'm going to complete my introduction and turn it over to Dr. Davis.
Thank you, Dr. Walton. It is a pleasure to be with you this afternoon. I am Dr. Sheila Davis. I am the Director of the Office of Health Equity for the state of Colorado. My interest in health equity actually began as a medical student in Philadelphia. I noticed that my patients who lived in neighborhoods that were adjacent to oil refineries were presenting in a more severe state than my patients that lived in the more affluent suburbs. And they presented with all sorts of respiratory illnesses and cancers. And I was a medical student at the time, so I was focused on treating the individual, and I hadn't zoomed out at that point and considered the population. But then when I did my pediatric training in Canada, in Montreal, I noticed the same thing. My Indigenous patients were presenting with diseases that had been eradicated in the general population. And I thought, Canada is supposed to have this strong social safety net, but yet I was still seeing this. And so I had the opportunity to work on one of the Healthy People Progress Reviews. This is about 20 years ago. And that's where I studied health outcomes data that was disaggregated by race. And what I saw in the numbers, it correlated with what I saw in the clinics and in the hospital. And that at the time, life expectancy for American Indian male was around 50, and it was around 75 for a white male. So huge discrepancies. And so I was so upset that I decided to join the movement to achieve health equity, and I haven't looked back since. And so I spent a good 10 years in Washington, D.C. I worked for a nonprofit on Capitol Hill that was all about providing technical assistance to grassroots organizations across the country that were trying to address these issues in their respective communities. And I remember we put together a universal health care bill. It went nowhere in Congress. This was during the Bush 2 years, so it wasn't ever going to go anywhere. And then finally, Obama was elected. And at that point, I was invited to serve as the associate director of the research arm of the National Medical Association. And the National Medical Association is similar in some ways to the American Medical Association. It formed because physicians of color, female physicians, physicians from other countries were not allowed in the American Medical Association, beginning, I'd say the first 50 years of the 20th century, probably 60 years. So the National Medical Association formed as an advocacy organization, professional association for physicians of color and the patients that they serve. And so this was around the time that Obama was elected, and we were invited to work on some of the provisions in the Affordable Care Act. And I thought, well, once we pass the Affordable Care Act, people have access to healthcare, that'll be a huge game changer. And while the Affordable Care Act increased access to medical care, now millions of people have access, we still see disparities, particularly in red states that have not expanded Medicaid. So I really thought deeply about this, and I realized that we needed to go further upstream. Access to care is important. Adopting healthy behaviors is important, but if an oil refinery is in your backyard, what are you going to do as an individual? We have to look upstream to systems. And so Now I left the DC area, I moved to Colorado, and now I'm the director of the Office of Health Equity. And we are charged with dismantling structural barriers to optimal health for everyone. So I am in the process of drafting policies for state agencies that include Department of Education, Department of Corrections, Department of Transportation, because we know that health equity is an issue that lives outside of public health and outside of healthcare delivery, although those are very important. But if we are going to move the needle, we have to look upstream, and COVID has certainly demonstrated this. I'm going to stop and I'm going to turn it over to Ola. Is it Olamide?
Yes, but you can just go with Ola. That's easier.
Ola. Okay, thank
Ola.
you.
Yes. Hi, everybody. It's a pleasure to be here with all of you. I feel honored. My name is Ola, and I am a nursing student, and I also working as a nurse right now. So I'm in school for the rest of my nursing program. I work presently. I also do work on campus with the E3 at Pennsylvania College. It's called the Education Excellence and Equity Office, where we improve access. We will let students know the access they have to the facilities in the school to help them graduate and finish school. And that's the work I do as regarding diversity. I am also one of the global-minded, one of 15 students that was selected for a mentorship program with Global-Minded, and that's why I am here. And that is all. Thank you very much.
Fantastic. There's so much here and so much expertise, and frankly, I think trying to keep this conversation fairly informal. I think maybe what we can do is just start off with really a discussion. And by the way, I would also encourage all listeners to drop comments or questions into the chat. We're always happy to aggregate them and then present those as well to the panelists. But let's just start off with a really basic question, I think, among the panelists, which is, what do you see as the long-term and the long-range impact of COVID on African Americans? It is fundamentally a respiratory virus, but the impacts are seen broadly across so many domains in education, housing, education, healthcare broadly, economics. So I would be curious to get your perspectives on the long-range impact that COVID may have had on Black communities in the United States.
There's so many directions that question can go, but I'm going to share it from my perspective. I'm going to talk about the fact that the pandemic created this space and a conversation about all of the discrimination and inequities that are happening in healthcare delivery. So that's where I want to focus. The healthcare experience for African Americans, people of color, marginalized communities is pretty atrocious. It starts from something as simple as just having a conversation with your healthcare provider can be an incredibly hostile experience. And patient satisfaction amongst African Americans is consistently incredibly low. We hear that healthcare providers don't listen to us, they don't hear us, they discount us. And then you add a disease and a disease process that inevitably keeps healthcare providers in their reptilian brain, meaning it's an environment where they're incredibly busy, overworked, understaffed, underappreciated, scared to death about their own mortality. And that creates just an unfortunate interaction, meaning the healthcare provider isn't in their best self They are working from a brain state that is more where decisions are being made more from the unconscious. So when we make those unconscious decisions, they tend to be riddled with biases, prejudices. And so the pandemic created an interaction between healthcare delivery and patients and exponentially made it worse. My fear is that although we've shown this light on inequities and discrimination and the healthcare experience of African Americans, my fear is that as we plateau, as things settle out, as the COVID-19 virus starts to act more like the flu, that we will not use this experience to do a better job. That's my fear. My hope is just the opposite, that we will use this experience because we've learned things, the light has been shined on situations that people won't forget. So my hope is the advocacy around health equity, patient satisfaction will improve. I would like to share another thing, and that is when Dr. Davis talks about going upstream, I do believe the answers are upstream. And there's one area that I've been working on recently that I believe also is an important thing to think about in healthcare. And that is, the research tells us that diversity matters. When you look at business, and especially at the level of governance, I'm talking about business in the boardroom where the executive decisions are being made. When diverse perspectives, diverse ideas are in that space, amazing things happen, creative things happen, innovative things happen, success happens. And more businesses have declared that they're in business to do social good. The boardrooms in America that have the least diversity are healthcare boardrooms. And so I really appreciate what Dr. Butler was talking about in terms of educating the importance of creating those pipelines and getting more people of color, specifically African Americans, in the healthcare arena. At the same time, I would encourage us to advocate for diversity at the board level, where the big decisions are being made around how healthcare systems are being guided, the decisions they're making, their relationships with the community, their bottom line, what they value, what's most important. So I just offer that as another thing that we should be thinking about, is the business of healthcare, and where many strides in creating more health equity can happen, where those larger decisions are being made.
Thank you.
Excellent, appreciate that. Wanted to ask Ola if he wanted to reply to that question around where we see the African American population after COVID, the long-term effects.
Yes, I think from my perspective as a student, I would like to say that I believe that I want to believe that this pandemic has generated a lot more interest in the healthcare field, healthcare profession, and more students of my color are willing, they are more ready to explore a career in healthcare. And I see them, people are talking about it regularly. People come to talk to me about how they get into, say, nursing and things like that, which is good. My only issue, being gender biased now, is that I'm the only Black male in my class, in my nursing class, and that's it. And I have no other Black men has come to ask me any question. So that is something that also I feel like it's important to talk about. But generally, as a student, I know that it has improved, it has increased the desire to want to join the healthcare field. Suddenly, it is attainable, is reachable. It's a goal that can be achieved, and more people are willing to do it. In the long term, also, I believe that for African Americans, I believe that this pandemic also, I believe that it has created a discussion also about science now for us, because and also it has really exposed also the knowledge or ignorance in our community. And how, I mean, I will not, I don't want to excuse the incident of the past, but also how long are we going to hold on to that? When do we start looking to the future and trying to adopt and try to, to adopt, to reason and to see and really think critically about the current issues and see how we can adapt and move on forward and move on. So,
well, you bring up a really important point, and Monique, maybe I can put this back to you, is that pipeline of traditionally marginalized populations that are then in turn going into healthcare, and what are organizations able to do to strengthen that pipeline of healthcare workers? And I think there's two reasons. Number one is a simple one, which is that we need more Black and we need more brown providers. So it's just a basic concept of more providers from these communities. But secondarily is the recognition that education creates a hedge against some of these healthcare threats, without a doubt, because there's a close correlation between the clinical outcomes and levels of education. So Monique, maybe you and I could both share a couple of the efforts that our organizations are trying to make to strengthen that healthcare pipeline in education.
Sure. I mentioned at the top of the hour the partnership with Florida A&M University. I am stationed here in Tallahassee. I should say our home office is in Tallahassee, and FAMU is just right down the street. And many of the individuals who sit on multiple boards with me that I am at dinner with are in the leadership roles at Florida A&M University. So we were able to just reach out and partner with this historically Black university, but we're also partnering with our Hispanic serving institutions, our HSIs, and put forth a $10 million donation to those schools. Sort of putting your money where your mouth is. We can have these conversations repeatedly, but if we don't put economic base behind the vision of pipelining, then I would say we're wasting some time. So we came to the plate with that to ensure that, one, the relationships are there. And when we are dealing with, like many other industries around the world, the globe, because of this pandemic, a crisis and staffing shortage, making sure that we have great partnerships with local institutions, particularly those that will help us diversify our workforce, is a crucial initiative for us. And then secondly, in addition to those individuals who need to be at the bedside, to the point that Dr. Walton just mentioned, the leadership at the hospital is what sets the culture for each of those hospitals, in addition to the boards. And so the partnership with FAMU was intentional, not just around the bedside individuals, but the leadership. And so the partnership with the School of Allied Health is that same school that produces those individuals who have a business degree or a master's in health administration. We want them in our boardroom, starting at our manager level, director level, and even in our C-suites, once they've been able to get that experience within our hospitals. So I think that intention of partnering with those institutions, one, Pierre, not reinventing the wheel, because they're right here, they're in our communities, they are working, tirelessly to educate individuals who we want to help us diversify our workforce. Just making those partnerships by just having those communications and finding that strategic win-win was the approach that we took. And then later hopefully before the middle of the year, we'll be having a health equity conference, because there's been a lot of conversation. I'll tell you that I am optimistic about the future of African Americans in this country for two reasons. One, COVID this is one of the silver linings, I think, of the pandemic, is that it just raised the curtain around many of these disparities that I heard about at Wayne State University as a freshman, as a first year student, where it was, African Americans tend to suffer more from this. And I knew that with my family members, but not necessarily as compared to other ethnic backgrounds. But so we've known this for a while, but there's really hasn't been an economic force tied to these disparities. So I'm hopeful, I'm optimistic that the conversations will continue now that the curtain has been raised and we're in this milieu that we're in now. But I know what we got to do, to everyone on the panel, is to collaborate. When I Google health equity and solutions, there's so much out there, and there's boiling of the ocean. And I think we need to figure out as a entity, which of those organizations we get behind, like Global Minded, which of those legislative conversations we need to be in when it comes to allocation of funds, and then which of those disparities are we going to look at? For me, it's maternal mortality, and I want to be front and center in having those conversations, just because of what the data that's being shown. But I could talk for a while. I want to punt it right back to you, Pierre, tell us about what J&J is doing. I see Carol has a question though before we go there.
Well, I was just going to say Sheila has to jet. So if you guys are okay, let's do Sheila, then Pierre.
I'm sorry. Yes,
that's
Sheila.
Okay. Yeah.
Dr. Davis.
Thank you. Celeste, can you pull up my 2 slides? So this is what we are dealing with in Colorado. And after 2 years of the pandemic, I'm sure you've gotten used to public health doctors get on television talking about flattening epi curves like Dr. Fauci. I am no exception. So let's look at the change in life expectancy over the course of 1 year. In 2019, on the left, African-American life expectancy is 78, which is below the Colorado average, not good. And life expectancy for other communities of color is, we have 81.4, et cetera, 83.4 for American Indian, Alaska Native. COVID hits. We see in the course of 1 year, the life expectancy plummet for all races, but it's the most pronounced for communities of color. So African Americans was started at 78 and we are now down to 74.1. So how are we going to change that? Well, we have to look at determinants of health. So my message is upstream today. So if we go to the next slide. Perfect. So if we think about what are predictors of our health outcomes, what determines our health, we certainly think about health services, what happens within the healthcare system, but it also has to do with employment, working conditions, education, literacy, physical environment, social support networks, personal health practices, coping skills, healthy childhood development, adverse childhood experiences, that's where that comes in, biology and genetic endowment, culture, financial and social status, and gender. So if you think about who has access to quality housing historically, who has had access to quality education, who has had access to credits, just go down the list, and you begin to understand why we see these health inequities, because life expectancy has everything to do with policies that determine the allocation of resources that shape health and well-being. So if we are going to tackle this issue, I think it's wonderful what Dr. Butler's organization is doing, but we have to address all of these determinants. We have to address policies that impact all of these determinants. And so that is a conversation I'm having in what I'm doing with the Office of Health Equity, but I'd like to broaden that conversation for Global Minded to have that conversation. I'm going to have to go. It has been a pleasure to be with you.
Yeah, certainly it's a great point, Dr. Davis. I don't think anyone would disagree with the notion that upstream determinants of health are where the focus must be in order to ultimately overcome disparities. In fact, that is the nature of disparity work, is to address those upstream determinants. So thank you so much for sharing that. Really very helpful. So I guess maybe Dr. Walton, I can turn to you and to Monique, perhaps you as well, in that somewhat we've talked before in this conversation about unmasking of inequities and disparities through the pandemic. And I'm wondering, how has that really influenced your missions at work? In other words, is the role that you now have professionally, and Ola, this is for you perhaps in your nursing career as well, has it changed as a result of what you've seen in the last 2 years and the differential impact on communities of color?
Well, for us, we wanted to make sure, and remember that I work for a hospital corporation. We wanted to make sure that our executive teams at our facilities, and we have over 180 facilities across the US and UK, were resemblance of the communities that they serve. So we set out metrics, particularly that our CEOs and our leaders had to be responsible for, our HR, where we wanted to improve the numbers year over year after, of course, 2020 and the George Floyd incident, to make sure that we were tracking our increase in diverse leaders, just like we track our quality metrics, just like we track the number of sepsis occurrences that happen in our hospital, for example. And so we've been successful year over year from 2020 to 2021 with increase, and there's still work to do. But I think one of the most important aspects of being able to make improvements is you measure what you treasure, right? And so the scorecard has to resemble the improvement in diversity within our senior leadership is where we wanted to start, because we feel that they set the culture for the hospital. And once we're able to do that, then we're able to, of course, impact the frontline staff. And then also the second piece of it is in our graduate medical education and recruiting those physicians. Low number of physicians, 13% of the population is African American, only about, I'm hearing 4% of the physicians in this country are African American, and about 7% are African American students, medical students. And so there's work to be done, to the point that Ola made, and starting early with pipelining. So we're looking in that aspect too. We got to have the candidates who want to go to medical school, and we need to do a better job of getting those individuals in high school or even earlier. So those are two areas that we're working on, particularly the leadership, but then also the graduate medical education.
About 6 years ago, I retired early from medicine to pursue my dream of being a healthcare provider trainer around issues related to diversity, equity, inclusion. There's a lot of resistance to that education in healthcare institutions. And there are lots of reasons for that. George Floyd was murdered, and I got pulled into a different conversations in the same area, but instead of working in, instead of training folks around implicit bias, I realized that part of the reason that there's so much resistance is because we need some healing. It's as simple as that. There is so much resistance to having conversations about race and racism because we are wounded. It's clear why people of color are wounded. We're experiencing this discrimination the moment we walk out of our front doors. But for the first time for many white Americans, they woke up. There was a conversation to be had. The issue is, how do I have a conversation when I am so afraid? And so I quickly, in the community work that I was doing, I quickly started bringing folks together across race to have these very brave conversations, healing conversations about why are we where we are? What are the myths that we've been told since the moment we started school? What are the issues? What are the hard conversations we need to have? Black folks didn't come to that table not knowing what the issues were. We live it. But there are well-meaning, well-intentioned white folks who said, I had no idea that this was happening. I had no idea this was the history of our country. So how do we have those conversations? And it involves real intentional behaviors and practices that not only take the scab off of the wound, but then help us to heal the wound. And so that's one of the things that I've been very active in the last couple of years. I teach a course on racial healing at Sac State University. I teach a course on implicit bias at Sac State University. I teach, I'm involved in facilitating a community process called Coming to the Table that brings people together on a monthly basis to talk, have those brave conversations about race. At the same time, I was invited to support a startup company that started because three very, very wealthy white men were marching with their teenage and college kids in Black Lives Matter marches. And they got together and they said to each other, what are we going to do? We have to do something. And they were like, well, one said, I'm on a board. I'm getting ready to leave a board. I'm going to recommend that my board seat go to a Black professional. The talent is out there. We know that talent is there. It's just, let's open the doors. That's what he did. Next thing you know, the three of them sat down and started a company called Take Your Seat. And Take Your Seat is on a mission to put Black professionals in boardrooms, as well as train boardrooms to be inclusive and create a culture of belonging. And what is the connection to health equity? I believe that connection to health equity is getting more Dr. Monique Butlers in board positions around the country and health institutions to open them up to see the good they really could be doing, that we can decrease health disparities. We just have to, at the highest level of governance, change where our priorities are, change how we're doing business, connect with our communities, right? If I'm a health institution who has all the health knowledge to transform a community that's environmentally toxic and literally down the block, how do we create those community relationships? And it starts at the board level to make a commitment to do that, to change the environment down the street. So that's another, I would have, that company found me. I wasn't looking for it, but when I heard the mission, I was convinced I was in the right place. So I guess in summary, I would like to see more Dr. Monique Butlers in those same positions of decision-making that she's in right now in every healthcare institution across this country. And I believe that it's not the only way to increase health equity in our country, but I think it would be a powerful way.
I thank you very much for what you just said, Dr. Walton, because it was really inspiring. I do have an observation that I feel like we should not ignore. Policies are being made. Eyes are getting open. Policies are being made. But I don't want us to forget also that those policies are getting pushbacks.
Mm-hmm. Mm-hmm.
There is a culture war going on. So I think we should also look, it would also be good for us to discuss how can we continue despite the opposition that we are facing. Because it's like we're trying to heal, yet the wound is being reopened every day. So are we truly healing? Or how can we heal irrespective of the pushbacks that we are getting? I think that's also something we need to discuss. And also, now I will throw this challenge to this question, and I'm not being rude or disrespectful to the three of you here who I'm like people I look up to, Doctors Walton, Theodore, and Butler. Do you have people you're mentoring to take over, to follow in your footsteps? Do you have more than one person? Because I think these are questions, these are things that we need to do while the whole process policies are being made in a larger picture. Thank you.
Yeah, I think that's a very important question because you're asking each of us to take some degree of personal responsibility in driving diversity and equity and not rely on policy and something that's done by someone else. What are the personal steps that we can take? So I just speak for myself personally, what we've tried to establish at J&J, and I've been a leader in getting off the ground, are mentorship programs across the US in medical schools where we actually bring medical students in and train them on what a large multinational pharmaceutical company does, hopefully in anticipation that some fraction of them will actually join us in leadership roles, as Dr. Walton was referencing earlier. So I think you make an important point, Ola, and that is that we all really take our personal responsibility for diversity and equity.
Yeah, I agree. You know, I have a number of programs, actually not a number, 3. So Pathfinders in Medicine is a program that I started through the University of Michigan for kinesiology students, which was my undergraduate. This is a brand new foundation under my Grant Foundation, which is my mom's maiden name, where we fund the books and tuition and some of the other issues that I had at the University of Michigan as a young, as I mentioned, first generation college graduate, not being able sometimes to pay for my books or having to work additional jobs. And so this foundation is giving back for a particular student, very sort of meticulous guidelines around who will be approved for that. They have to be in kinesiology. That's one. 2, when I was a medical student at Wayne State, it's still in progress. The Young Doctors of Detroit program I started with Dr. Eddie Patton. We were all medical students. He's currently in Houston now. He's a neurologist. And Dr. Jimson Smith, who's the ER doc now in Atlanta. And we've been in the process of trying to expand. Wasn't able to do it in Denver, but we will start a program here in the Tallahassee, Florida area this year. Just got funding for that, where students are taken from their high school. They are partnered with physicians to see OB in the OR. They go to see in pathology to see autopsies being done. And it just helps them with, if you can see it, you can be it. And so that process we have in place. And then finally, I have a large number of mentees that I have a difficult time trying to keep up with, that my assistant, I just gave her about when I first started this position, that list to help me in checking in with them because that number is growing. But it's a long process. The Young Doctors of Detroit has been able to graduate 6 individuals from high school to medical school. And people say 6, you know, that's just a drop in the bucket, but it's such a long process getting them from from high school. And so now we're going to expand. And I know Carol and I have been talking about this more than just physicians, developing physicians, but more along the allied health, like I talked about with my company. But yeah, I can't be here on the panel or be in my role. You know, I appreciate what Dr. Walton said, but there's a lot of, meaning we need more of me. I agree with that, but there's, to Ola's point, a lot of pushback and a lot of hurdles that we have to overcome. But my own personal responsibility in giving back and ensuring that people see me and see if I could do it, they can as well. And last week for my daughter's adjusting to Tallahassee. So we're from Detroit. We lived in Denver. So now we've been in Tallahassee for a year, our first time in the Southern sort of milieu. I put together a panel of Black professionals for her school so that she and her Black colleagues can be proud and see the individuals who give back to this community. And that program went over very well. So it's a constant situation where we have to be intentional around giving back. And if I didn't do those things, I wouldn't be me. But to your point, I want to go back to what you just said. You know, I did say I'm optimistic, but there's a lot going on right now. When you talk about critical race theory, or you talk about the abortion bans, and how a lot of what's happening can even expand the disparities that Dr. Theodore started out with. You know, some of those policies and that pushback, to use your term, Ola, is prevalent and it's rapid. So at the same time, with the push and my optimism for the unveiling of what's happening in our communities with COVID, there's still a lot of, you know, forces that could cause the disparities to increase. And so I'm very cognizant to that. And want to talk about, before we end at 4:51, some of those key solutions. Dr. Walton, you talked about board, you know, membership, which is so important. And we talked about leadership in our hospitals where people are really vulnerable, needing care. What are some of those other solutions that we need to have recorded and hold ourselves accountable to as a health equity team? We've been in place for about a year now, and want to just be able to check off some solutions that we've been looking at and wanting to ensure that we're closing the loop on those. I'll kick it back to you, Dr. Theodore, and then anyone else who has comments on solutions.
It's such an important question, because the really question comes down to what are the concrete steps that we can do to move ourselves into a more equitable healthcare system. And one of the things I've thought about this is that a way I've thought about this is much how we've thought about safety over time in the practice of medicine, where there is a certain expectation that safety metrics will be met in the delivery of healthcare. And if those metrics are not met, then the hospital is held accountable, either in terms of reimbursement or some other penalty from a payor. And I think that same sort of movement needs to take place with respect to inequities. It can't just be that there's a difference in outcome for surgical care or for HIV management in one population versus another without some consequence. So I think we have to raise our expectations that these disparities, these inequities should not be sort of accepted as business as usual, but that it is an unmet need, and there's a requirement that healthcare systems and healthcare providers must have to narrow those population health differences. So one of the things I'd like to see in the corporate sphere is we start to think through what are our commitments around equity and the environment and social issues and governance, but also start to think about how do we make commitments around health equity as well, where everything from a TB-free workplace for environment, for example, but an entire set of expectations to try to limit those differences in population health outcomes is, I think, something we can ask of ourselves and of our institutions and of our companies. Maybe Dr. Walton, I can throw that one over to you. I think that's a great question for us to really end on, is what are the concrete steps we should take going forward?
I love your step. I absolutely love that concept of holding healthcare institutions accountable, using metrics, tying it to the bottom line, as opposed to, what was the phrase you said? Business as usual. There's so many things that we can do moving forward. In my sphere, I'm in the diversity, equity, inclusion sphere. So I'm what seems to be working at the personal and interpersonal level with supporting people joining the movement to make systemic change in healthcare. And it's not just about knowing a lot of facts. It's also involves increased awareness, and it involves heart change. And that's the business I'm in, encouraging those brave conversations to be had between all the parties involved about how we can move the needle in terms of health equity. And I think those conversations, The higher you go in the organization, the healthcare organization, the more powerful those conversations can be, the more impact you can have on policy. And I love what you said around connecting that work to metrics. You know, where are we going? How well have we, what is life expectancy this year at this hospital around this particular disease? Where it's very objectified. We're in healthcare, we're scientists, we love data.
That's right.
It just seems like a slam dunk. I was talking to a gentleman who's the health equity specialist at the SEC. And he said, you know, we have no problems diversifying our portfolios. We know that makes financial sense. Why are we what is the barrier that keeps us from diversifying at the higher levels of leadership in our companies? And you all know it's not about not having enough talent. The talent is there. I love Heather McGee's book, The Sum of Us, because her main message was, this isn't a zero-sum game. And that's one of the myths that people are just hung up on. Well, if I give up a little power, you know, or if I bring someone else in, I'm going to have to give up something. But the reality is when you bring in the diversity, the pie gets bigger.
That's right.
So even if your slice is smaller, proportionally, you still get more. And so I think dissolving that myth that you're going to lose out on something if you open the door is really important. And with that, I'm complete. I do want to say one more thing. Ola, there are phenomenal programs across the country for mentorship and support in what you're doing. And all the mentees that I work with, I tell them to just start first with the Google search. Start with the Google search, and you'll be hopefully pleasantly surprised to see that there's support for you there. And then the other thing I say to students is, whenever you're in a space like this, everyone in this space wants nothing but your success. I'm on LinkedIn, I'm on Facebook, right? You know, when you meet someone who is invested in your success, reach out to them. Don't hesitate. Don't get stuck in, you know, am I worthy enough? Am I smart? No, reach out. Reach out. People, I'm where I am today because, like Dr. Butler, I'm first gen for college. I didn't know anyone who did medicine. In fact, I look back and I'm like, where did I get this idea? And the amount of support and love and care I got in my journey to become a physician and to remain as a professional has been unbelievable. So reach out.
Excellent. I do want to answer the question that was posed in the chat regarding what can our white peers or white healthcare providers do to promote and help ensure diversity and equity is created and upheld. You know, I think the main answer that I would give, and I would welcome anyone else, I know we're just 1 minute away from stopping, is speak up, right? To be an ally, primarily if you're a provider, and when you notice at the top, I think that's what we've talked a lot about today. If you're in a clinic or if you're in a hospital or whatever role you play as a provider, and you see that there's an opportunity to have more diversity within the ranks at the very top of the organization, speak up about that. Challenge your HR person to ensure that there are metrics that they're looking at and that there's at least diverse candidates for each open position that's there. And then having those conversations around ensuring that there is diversity. I think that's where we start. I think that's the opportunity. Anyone else want to weigh in on that? But before I turn it over, I do want to say, Theodore, your point is so well taken regarding the payers. Many of my friends that I went to business school with are now chief health equity officers for Optum. Florida Blue just announced one. Many of our Blues across the nation and the states have chief health equity officers. And the Affordable Care Act placed, and we need to pull that out and dust it off and make sure we're aware of it, is that there is an obligation by 2024 of certain health equity metrics that have to be met for reimbursement at the hospitals. And that's how you do it, like CalMed did in California. They made sure that if your NTSBC section rate is at a certain, I think is above 25%, your reimbursement is going to go down from a Medicaid provider payment because you're not meeting those quality metrics. And that's what we are anticipating with the payers. I think that's where it needs to start from an economic perspective.
Great.
Well,
Carol?
we're at 5:01, Carol. I think we should go ahead and end. I know I need to sign off, but Dr. Pierre, I'll hand it over to you to close, or Carol.
You know, I think you said it all, Monique. And so maybe Carol, you can give us a couple of closing remarks and we'll call it a day. I
You
really
bet.
appreciate all our panelists on the really remarkable input. It's clear there's a lot of work to be done, but in fact, there's a lot that has been done. And I think the pandemic has really opened our eyes to some of these really clear efforts that need to take place with respect to health and health disparities. Carol, over to you to close us out.
I agree. Thanks so much. And I'll just say for any of you who are tuning in for the first time today, the global minded community is several thousand people like these amazing individuals. And I think that so much of the world's problems can be solved by what we call radical collaboration. And it's working with people who are the uncommon collaborators. So we want to invite all of you to meet these folks in June. Global Minded's conference is June 22nd, 23rd, 24th. We are really excited to be live in Denver this year after 2 years of being virtual. And we'll have many students there like Olaf today. We're so glad he joined us. And we look forward to it. And if you're not on our newsletter, you can go to globalminded.org and sign up for the newsletter. All of our events are advertised in the newsletter. And also every day in the newsletter, we profile incredible people who have overcome the odds, and they're role models really for all of us, but especially for students like Ola and so many students that are going to be our future leaders. So thank you for your time today. Thank you for your commitment to health equity and for the hard work and sacrifices you're all making. And we look forward to seeing you next month. And March is where we celebrate International Month of Women, and we'll have an incredible session here on the last Monday of March. And we hope to see you all then. Thanks to everybody today. Great to see you. Until next time. Bye-bye.